Imagine, if you will, a sound so extraordinary you can see it. What? Ultrasound! Welcome to Bedside Ultrasound of the Lung by Sean and Michael Currie. Although ultrasound has been used in diagnostic medicine since the 1940s, it wasn't until the 1980s that practitioners found use of ultrasound for the lung. What was once considered no more than artifact noise has now become one of the most efficient ways to evaluate the lungs in critically ill patients. Ultrasound is highly portable, faster than X-ray, and very sensitive for lung pathology. There are many indications for ultrasound of the lungs, which includes many of the things we encounter on a daily basis in the emergency department.
When it comes to probe selection, each probe has its benefits. The linear probe is high resolution, low penetration, and is the best probe for lung sliding. The curvilinear probe is low resolution, deep penetration. It may be more beneficial for things like B-lines, pneumonia, effusion, and large body habitus.
The lungs are large organs that may have multiple areas of interest, so when approaching the patient for lung ultrasound, it is easiest to divide each lung into 2 anterior points, 2 axillary line points, and 3 posterior points as seen on the figures in the center. Areas of interest differ based on suspected pathology. For instance, for a pneumothorax, the patient should be supine and you should examine the anterior points. For edema or effusion, the patient should be supine or sitting up and you should examine dependent points. If you're looking for consolidation, all lung fields should be examined.
As mentioned before, lung ultrasound is the analysis of artifact. The beam encounters air at the interface between the soft tissue and pleural line. Air acts as an impenetrable, solid, impermeable, thick force field. The beam is reflected back, causing the artifact we know and love.
Lung sliding sign is the movement between the visceral pleura and the parietal pleura. It is visualized as movement at the hyperechoic line at the pleural level just deep to the ribs. This is the initial reference for all non-pathologic findings.
A-lines are the reverberation of sound within the chest wall. These horizontal lines are considered a normal physiologic sign.
B-lines, or comet tail artifact, are laser-like vertical, narrow-based lines arising from the pleural line to the edge of the ultrasound screen. They are generated at the alveolar level and seen if fluid or consolidation is present. The beam reverberates within soft tissue of thickened pleura or between the flooded alveoli.
Shadowing. It arises from ribs as shadows.
We will cover 4 of the major basic pathology that can be evaluated with the ultrasound.
When evaluating for a pneumothorax, chest x-ray is only 25 to 75% sensitive, where the ultrasound is up to 95% sensitive. If you see lung sliding or if you see B-lines, you know there's not a pneumothorax. You can use M mode to help look for movement. It is helpful for still picture evidence. If you have a pneumothorax, you will see lines instead of the seashore sign. Absence of lung sliding, however, does not rule in a pneumothorax. There are many things that can cause the absence of lung sliding, such as the absence of a lung, a mainstem intubation on the opposite side, scarring, blebs, or anything that restricts normal lung movement. If you see the lung point, this confirms the diagnosis of a pneumothorax. This is the spot where you get the transition between normal sliding lung and a static lung. Lung point on M mode is seen as seashore sign, followed by lines, then seashore sign, then lines again. Limitations to using ultrasound to evaluate for a pneumothorax include subcutaneous air, because then you can't interpret the lines.
Here's an example of normal lung sliding between the visceral and parietal pleura, ruling out a pneumothorax.
Here's an example of using M mode to help rule out a pneumothorax. We see the nice sandy beach down at the bottom. This is a positive seashore sign.
In this patient with a pneumothorax, you can see we've lost the normal lung sliding. This is the M mode appearance of a pneumothorax. As you can see, we've lost the sandy beach and have a flat line appearance. When evaluating for an effusion, you want to look between the liver and diaphragm on the right side or the spleen and diaphragm on the left side. Mirror image artifact above the diaphragm and vertebral shadowing below the diaphragm are both physiologic. Dark fluid and vertebral shadowing above the diaphragm are pathologic. In this slide, you see the mirror image artifact of the liver above the diaphragm. We interpret this as the lung. But you also see the dark fluid around it that we know is pathologic for effusion. In this slide, you see vertebral shadowing extending above the diaphragm. This is known as the spine sign and is also pathologic for effusion.
When evaluating for pulmonary edema, you want to use a low frequency or curvilinear probe set deep. Edema is present if you see 3 or more B lines per lung field. You can use the number of B lines as a way to assess the amount of edema present. There will be less B lines with less edema. ARDS and acute diastolic heart failure will both give you bilateral edema. To distinguish between these two etiologies, you can look for pleural line abnormalities, subpleural consolidation, spared areas, and non-homogeneous distribution of B lines, which points towards ARDS. These next 2 clips are great examples of edema. You can see there's more than 3 B lines per lung field.
Chest x-ray is 75 to 85% sensitive for pneumonia and only 67% specific. Ultrasound is 89 to 97% sensitive for pneumonia and 95 to 99% specific. You should use a low-frequency probe set deep. When evaluating for pneumonia, you must scan all lung fields. Look for B lines, tissue consolidation, and air bronchograms. Dynamic air bronchograms are more likely pneumonia, whereas static bronchograms may be atelectasis. Bronchiolitis may look similar, but also has pleural line abnormalities, small subpleural consolidations, numerous B lines, and you should not see alveolar consolidation or bronchograms. Here you can see the speckled and heterogeneous appearance of tissue consolidation. These are some things to pay attention to when evaluating the lungs with ultrasound. When identifying the pleural lines, use the ribs as landmarks. Exaggerated ventilatory movement, such as in pneumothorax, may cause muscle layers to slide against each other, causing sliding in the fascial planes. This is easily mistaken for the pleural line.
When evaluating for edema, be careful about subcutaneous emphysema. The subcu air can generate hyperechoic, vertical artifact, but they will not arise from the pleural line and they won't move with ventilation, and they may also obscure ribs. These can mimic B lines.
Finally, Z lines should not be confused with B lines. They are both comatose artifact. They arise from the pleural line, but Z lines do not extend to the bottom of the screen. They usually taper off at 2 to 4 centimeters. They do not erase A lines and do not move with respiration. They may be found in normal lungs as well as pneumothorax. Now go ultrasound something.